Hi. Right. Hopefully, I'm going to lean forward so you can see my name badge. We're gonna try and talk loudly. We've both got masks on because we're sat closer than 2 meters. I'm Sophie, infant feeding specialist midwife, based on the maternity ward. My office is on delivery suite, so I provide feeding support in addition to the wonderful midwives and maternity support workers and maternity care assistants that we have. I have with me Mel, sat slightly further back. Mel, are you happy to introduce yourself?
Yes. Hi everyone, my name's Mel. I'm one of the sisters on the neonatal unit here at Gloucester Royal, and I'm also part of the infant feeding team for the neonatal unit, and I work very closely with Sophie and her colleague Emma.
Yeah, brilliant. Thank you, Mel. And we have here Heather and her gorgeous daughter, who looks like she's being winded at the moment. Heather, are you happy to introduce yourself and tell us a little bit about how many weeks you were when you had your daughter, and kind of how delivery went, and a little bit about your breastfeeding journey?
Sure. So I'm Heather. This is Pippa. I had her at 35 weeks at Gloucester Hospital. She was obviously a little bit of a surprise. My waters broke, and then 13 hours later, Pippa came along. Breastfeeding journey, I was really lucky in that I had a really good milk supply and a really willing participant to feed. So in that respect, it was good, but there were quite a few ups and downs with the fact that she lost 13% weight loss, and she did have jaundice. So we were in a rigorous routine of 3-hourly feedings and top ups. But we managed it, and she's been breastfed ever since, and we're 10 weeks on, and she's still breastfeeding beautifully.
Amazing. And you, so it's really common, isn't it, for preterm babies? Jaundice is very common for preterm babies, and it can make them quite sleepy, can't it, Heather? And kind of, so because they can be quite sleepy, sometimes they only want to feed for a short period of time, or they're a bit reluctant to feed. So then you kind of, like you say, you get into kind of needing to express and give top ups. How did you find that first few days, Heather? The kind of, because she did short feed windows, doesn't she? I think from what I remember.
Yeah, I think that's what I kept having to be reminded of, that 35 weeks, she didn't have the energy to do long feeds.
Yeah.
So she'd go on and then she'd fall asleep. And I think what I wasn't realizing at the time is she wasn't getting that kind of good nutritive milk, the back milk. So although she was topping up, we weren't giving her enough. So it was just trying to get the element of top ups right, how much she needed, with also trying to give her the breast. So it was going on the first time, always giving her the breast and then topping her up. But then she just falling asleep, and I just thought that meant she was full. So I wasn't probably giving her enough top up as I needed to. And then eventually, when we realised that the weight loss was what it was on day 3, it was like, right, okay, we need to get this top up bigger to get her to put the weight on. So it's that position of a sleepy baby and trying to get enough milk into her.
Yeah, which can be tricky, trying to force feed a sleepy baby, can't it? So it's kind of, and that's where, utilising your support, the midwives, the neonatal nurses, whoever you've got supporting you around you. We often, we've got some feeding cues. So that's the one similar to I showed on a session earlier. That's a term baby, but there's a preterm baby one as well. So their feeding cues are often quite subtle, really very subtle. And often their time windows that they show those feeding cues are quite short time windows, aren't they, Mel? Would you agree?
Yeah.
So it's a case of we need to be kind of hopefully educating you, the staff should be supporting you to identify those feeding cues, because sometimes that's simply, it's just they've woken up and they start to kind of put their fingers to their mouth, or even more subtle ones than that. Wouldn't you agree?
Yeah. I mean, some of the smaller babies move very little at all.
Yeah. So what? I'm kind of more used to supporting with the like Heather's baby with 35 weeks. The more preterm is definitely more Mel's field. Any tips would you say on feeding cues and kind of time windows, I suppose?
So I think the time windows, I think when you've got a small baby, there's a lot of people talking numbers at you. They're saying things like, don't go longer than 2 hours, 3 hours, 4 hours. you know, make sure that they feed for this length of time or take this volume of milk.
Volumes as well,
and
isn't
I
it?
think that is so hard to actually move away from that. And I think it is a case of, you know, if your baby is just very subtly showing movement of their mouth, bring them out, put them very close to you. And then if they are ready to suck, they will start to latch on, they'll try and find the breast. And then you haven't missed that opportunity. And every time they have that almost like positive reinforcement, they're learning that that's what they do and that's the reward that they get for it. And then that helps us to move away from got to feed 3 hourly, got to feed 4 hourly, whatever.
Yeah, and actually that's where, again, skin to skin, so I was harping on about skin to skin in my last session. I'm going to harp on about it again now. Isn't it the answer? I think you two are fairly confident are going to agree on this. Skin to skin is a good go-to, a good kind of, it familiarises the baby as to where to go for feeding. They can smell the breast tissue. There's scent glands in your nipples around the edge of the areola, which help, sebaceous glands, which help secrete an oily substance, so the baby can smell to where they need to feed, smell towards the nipple. That's something all mums are encouraged on neonatal unit, isn't it?
Yeah, indeed. And
skin to skin.
You know, as long as possible. If you want to sit all day with your baby doing skin to skin, that's usually fine, as long as you keep the baby warm.
In some ways, actually, for your babies as well, for actually longer duration of time. So encouraging the fact that you've had a wee, you've got everything you need there by yourself. So you're not going to then go, oh, actually, I now need a drink, or I need to get a drink of water, whatever. For your babies, actually, they're better, aren't they, to have that longer period, so they're more stable.
Yes, yes. So the baby's actually being lifted out of their cot or their incubator. The process of doing so obviously disturbs them, and they need to have a little bit of recovery time afterwards. While they're having the skin to skin, then that already starts to release the oxytocin, which is the feel-good hormones that we all experience. And that helps them to recover quickly, and then they will settle down and enjoy the experience. And obviously, the more the baby enjoys it, the more relaxed mummy and daddy will
relaxes
be.
Mum,
absolutely. And then we go around in this fantastic positive cycle that everyone's enjoying the bonding experience as well.
And it helps the milk supply. So that oxytocin that Mel's just mentioned about kind of helps boost milk supply. And actually, we often encourage mums to express after they've done skin to skin, maybe during, if it's possible. It depends obviously on what position your baby's in, how many tubes and wires there are. But skin to skin before you do some expressing can really help. And expressing, you should be supported by staff wherever you are. So if you're on the neonatal unit, all our staff are trained to support with hand expressing. So again, all the different types of expressing, which I touched a little bit on earlier, but hand expressing, and then you've got pumps mums can use here, haven't you?
Yeah. So we've got lots of pumps around the unit, so you can just go and help yourself to those. You can sit and express next to your baby. You can have a privacy curtain if you wish. You could go into another room, which we call the milk kitchen, if you want to go in there just to get away from some of the noise. It's entirely up to you.
Yeah, because actually it's quiet in there, isn't it?
Yes.
So it's definitely, expressing is definitely a personal thing, in that some mums get on better with hand expressing, some mums get better with hand pumps over an electric pump, some get better with electric pump. Generally, our mums here on neonatal are supported to do double pump with an electric hospital grade pump, and doing breast massage as you express. But like Mel says as well, actually, where's that mum going to feel most comfortable? Because if she feels stressed, stress hormone cortisol will inhibit milk production. So actually, we need to encourage that mummy to kind of to express where she feels least stressed, I suppose, in a way. And yeah, you know, if your baby's skin to skin are doing that, they're brilliant. But actually, what will work for that particular mum? And yeah, we're kind of staff support really good at supporting with that, aren't they?
Yes. So each baby will have a nurse allocated to look after them and their family. And we encourage the nurses to speak a lot with the parents about their feeding choices, how it's going, any of their worries. We've got a lot of visual aids around the unit as prompts and little crib sheets.
I'm a visual aid fan,
and you know, little bits of guidance, some contacts that you can get in touch with. Obviously, we have Sophie and Emma as well. We also loan out breast pumps to mums to take home when their baby's in NICU. and that helps as well. We had one mum not too long ago who actually plugged it into her car while her husband was driving her to and from the unit each day. So she got an expression in on the way in and another one on the way home. So that's two out of her 8 a day that's done. So she felt she was using every opportunity.
Yeah. That's brilliant. Yeah, like you say, it's using every. Yeah, I do know. I supported a mum actually recently with. She had a car charger for hers for out and about if need be. Hand expressing in those early days. I showed one earlier, but that's a 1 ml syringe. For those of you that you might not have seen, it is fairly tiny, if I'm honest. But that's really, really normal in those first few days after you've had your baby. Tiny amounts. And that's absolutely fine and completely normal to be getting off that volume. And you have a lovely phrase, which I always love that you say in training. You use it for mouth care, but also, what do you normally say about with the colostrum?
So the colostrum. So there's familiarity in the colostrum as well. So the baby associates the smell of the colostrum with having lived in the womb of their mummy, and the colostrum and the amniotic fluid have got a very similar smell and taste. So the baby knows it's theirs. So it's like all mammals, they know to go to the right mum to start feeding. But we also, we have 2 drips and a dribble. Don't ever waste a drop of milk. We can bring it down to the baby and the baby can sniff it, they can lick it, whatever they
put it on their lips,
do. So we put it on their lips for mouth care. Some babies will absolutely sort of open their mouth and grab it and sort of want to take the whole syringe practically. Others are a little bit more tentative. So we just take it at their pace, really.
And there's loads of research showing that actually that even if it is tiny amounts, that's enough for that baby. So Mel's just talked about mouth care. It's enough for that baby to swallow down, and it triggers a positive immune response in that baby's gut. So it actually starts to build that baby's immune system from that mum's breast milk. We also know there's loads of research for mums who have had preterm babies. Their breast milk's really cleverly designed because our bodies are so clever that it's higher in protein, isn't it, Mel?
Yes.
So it's higher in protein for preterm babies because we know preterm babies need kind of higher levels of protein. So it really goes to show how clever our bodies are, and actually our bodies know that we've had a 34-week baby, and actually that's the type of breast milk your body produces will be tailored to your baby. It's so clever. It's magic stuff. Very magic. Any tips on expressing, Heather? Because you had to do a bit of expressing, didn't you, in the early days when she was quite sleepy?
Yeah. So we started off with hand expressing, and I got support from the midwife on the first few days. And like you say, the smallest amount is so precious. So you think you're getting small amounts off, but that's going to be enough for these little ones. Just listening to the advice of the midwives really, and how they're telling you to hand express, but don't be disappointed if you're not getting anything off to begin with. It takes time.
Yeah, absolutely.
It takes time. And then it's just knowing and trusting in your supply and relaxing and making sure that milk's coming through. And then we moved on to, once we were happy with the syringe, and I was filling quite a lot of syringes, I felt comfortable then to go on to the electric pump.
Yeah, your volume's increasing. Brilliant.
Volume's increased, yeah. But
did you find that quite comfortable to do the pumping?
I think, yes. Make sure you start on the lowest setting and get that advice. It can be a little bit rigorous, and I don't know whether you can do this, but I used a little bit of Lancinol on my nipple to put the pump on because it felt a little bit dry when it was pumping, and that can cause a little bit of soreness. So when I put that on, it helped ease.
Yeah, it helps stretch the skin tissue. Yeah, that would make sense. Yeah,
that I found.
Yeah. Mel, any kind of gems of expressing, because you must hear. So on neonatal, expressing is one of the key.
Oh gosh, we have a lot of tips and things. So obviously expressing near your baby, or at least looking up pictures or videos of your baby will help with that association.
You have those.
We've got V-Creates, we've got iPads as well that we link
cool.
parents up to, and we send them little videos and snapshots of their baby when they're not
you
with
do,
them.
don't you? That's lush.
So we can do that. And we've also got what we call bonding squares.
That's
So
the
some
one,
lovely
yeah,
little
bonding
fabric squares that we put in the baby's incubator with them, and mum and dad can put down their cleavage if they have one, and then they can swap them over, so the baby can smell mum and dad can smell baby if they want to have that
Yeah,
closeness.
I've definitely had mum say to me before about the smell.
Yeah.
Yeah, it's really helped them.
And if they've lost their bonding square, they can take one of the sheets or the baby grow or the baby's hat or any of those things, really, to just to remind them. Your sense of smell, your olfactory centre is really, really dominant when you've had a baby. And again, it goes back to when you were but we obviously we're all mammals. So it's crucial that you help your hormones to work in your favour.
So actually on that as well, it makes me think of two things. So I remember in my midwifery training, we were encouraged or taught not to wear any perfume where we went on shift, and I've kind of carried it through to recently, really. But not wearing anything highly scented. And actually it's something I tell mums often. So say if you've had your baby, you've done skin to skin, often you're very keen for that first bath or shower, but actually if you don't use anything highly scented, so you can get classic baby world, there's a lot of brands out there that have kind of latched onto, there must be products for babies and for boob. I bought a boob chest area cream to keep it moist and to prevent stretch marks. But actually if it's anything highly scented, it can disorientate that baby from where to find the breast. So kind of deodorant's fine, but I generally encourage mothers, particularly for their chest area, don't use any highly scented moisturising creams, perfumes, anything like that, particularly while in those early days, while you're establishing feeding, because that baby smells its way to the breast. So of course, if it's all it can smell is Dior, like it's just going to be overpowering to that baby. So that's always something I encourage mums, don't kind of just the chest area, don't put anything highly scented.
And we encourage the mums to rub a little bit of their breast milk around their nipples, and then the baby knows where they're aiming for, hopefully. And again, sometimes just a little bit of milk or colostrum onto the baby's lips as you bring them into
that
the
can
nipple.
Encourage them,
that might just start the
ball
ball
they get a little kind of lip and a kind of bit like, I like that, and that goes back to that positive, like a positive experience for them.
And as if you have a preterm baby, obviously they've still got a lot of development to take place that should have happened in the womb. So it's really crucial that all of their experiences outside of the womb are as positive as they possibly can be. So you don't want the breastfeed or any feed to become a fight, to become something that the parents don't enjoy and that the baby doesn't enjoy. Babies who have problems with feeding or have a bad experience with feeding can sometimes and then that also can lead on to speech and language issues. So the little steps that we take here are absolutely crucial for that development.
There's something you talk about in training that I always kind of link onto or remember, positive experiences, because they otherwise, particularly so babies on preterm, on neonatal units, particularly if they've had a lot of intervention, can have, is it orophobia?
Orophobia, yes.
Which makes sense. Actually, I've got one I've been referred one that the health visitors are concerned about with regards to orophobia, so it reminds me of a to-do. Any, I suppose, tips or...
So again, it's any time you're touching the baby's mouth, try and make it as gentle as you can. Don't ever be persuaded to open the baby's mouth for them. They need to be ready to do it themselves. So as we've already said, if you put a few drops of milk on their lips, then they will learn to lick that off, and then that in turn will lead to them opening their mouths.
Well, it makes me think as well, actually, and I know that's something kind of Heather as well, the fact actually it's almost a case of accepting you're going to be here for a while and your baby's going to be here for a while, and when they're born early, because their feed windows are early, their feeding cues are subtle, and sometimes it's just, isn't it, Heather? It's just a case of sitting tight, feeding, and kind of almost take each day as it comes, particularly when you kind of, there's a few mums I've supported recently, and I've described it as a bit like 2 steps forward, 1 step back, where you're doing well and they're having a sleepy day and you've really struggled to do any breastfeeds, and actually you found yourself doing cup feed or NG tube feed, which Mel's going to come on to. Would you agree, Heather, that kind of, yeah?
Completely. I was so unprepared for how long I would be in the hospital for. I'd be
Yeah.
out on day 2. I'd be quite competent with feeding and everything, but then luckily they said no, stay till day 3. Make sure she gets weighed. Make sure.
Yeah, we got to wait. Yeah.
So you don't have to come back again. And so when we got to day 3 and there was the weight loss, we had to stay in again. And it is, you just have to dedicate that first week to feeding. It is.
Yeah.
That's what your aim is just, if that's what you want to do, you just
it's almost like your sole purpose really is feeding, expressing and feeding, and trying to and just sitting tight. And
knowing that because I just felt that I didn't want to waste people's time. I was reluctant to ask for help, but in the end I just thought, actually no, this is what I need to do. I need to ask for help, because that's what the midwives and support workers are there for, and they're fantastic at doing that, and they will help you and support you in those, and that's what you need for that first week, if not a little bit longer. I think just dedicate yourself to that if that's what you want to do, for sure.
Yeah. Thanks, Heather. Thank you. And particularly during lockdown. So you had PIPs this whole lockdown, and that's the thing. I'm well aware, and that's why we're trying to do these virtual support things. Strange times at the moment during lockdown, and limited kind of seeing your partner and the kind of everything that comes with that. So doing everything, staff will go above and beyond, doing everything they can to support you to try and minimise your stress levels. And Mel said about the different options available for neonatal, so they can see their babies. Mel's going to talk a little bit now about, so on neonatal unit particularly, there's various different feeding options. Obviously breastfeeding for those, the older babies, but they develop their suck reflex. I'm going to let you talk about kind of when they develop their suck reflex and the different feeding methods. So Mel's going to run through that.
Okay, so the vast majority of babies who come to NICU will be preterm, and the majority of those will be born between about 32, 34, 36 weeks. So the breathe, suck, swallow coordination doesn't always come to the fore until about 34, 35 weeks, and some babies even later. So round about 32 weeks gestation, we're starting to see the preterm babies maybe move to suck their fingers, stick their tongues out, start to lick their lips, or even open their mouth. And it's very positive for mummies in particular, if they're holding them, that the babies start turning towards them or turning towards the breast. But obviously, if the babies are born early, or if they are born sick, too sick to feed themselves, we have to think of some other ways to get nutrition into them. So in the extreme cases, then we have to put a little drip into their arms or their legs, or even through their umbilical cord if it's in the early days. And we can give them specially prepared fluids from pharmacy through those. And then that meets their basic hydration needs and their nutrition needs. There will come a point where we have to start thinking about putting milk into their tummies and getting them used to that. So again, if they're not big enough or mature enough to cope, we'll pop in a feeding tube, which I don't know if you can see this. It's a very fine thread-like tube that we would pass down either the baby's nose or into their mouth, and it goes down the back of their throat and into their stomach. And we can pour their milk into that very, very slowly, very, very cautiously. And over the course of weeks or even months, we increase the amount of milk that they have, and we reduce the amount of drip fluid that they're having. So then we start moving on to the point where they start to have their suck feeds. And as Sophie said, and Heather has done, the magic syringes of the special nectar come into play then. So the babies are already starting to get used to having had the colostrum or a little drop of milk in their mouth, and we can start building that up. But once they get to about 3, 4, 5 mils each time, we'll then start introducing this little device, which is a feeding cup. I don't know if you can see the little lip on it, just that side there. and we can put mummy's milk or whatever milk the baby's having into that, and then we start feeding them. So it's not a case of pouring it into their mouth. You would hold the baby nice and close. We'd actually swaddle them with their hands up to their mouth. It's really important when a baby's feeding that their hands are near to their face, because they have that association with their mouth. If their hands are at arm's length, they're going to be concentrating on what's going on around here. But if you bring their hands in, it calms them. Just like those of us when we're nervous, we fold our arms or we bite our nails. That's reassuring. So it stops the baby using up lots of energy, and then they can also concentrate on having the cup in their mouth. So we literally would tip a little bit of the milk to their lips, and then they would lap it up. So the preterm babies tend to literally lap it up like kittens. So they stick their tongues into the milk and then squish it back into their throat, and hopefully coordinate and swallow in the right way. Obviously, the person who's feeding them, it might be a nurse, it might be one of the parents, learns to pace the baby so that they can actually take a suck and swallow it and have a little recovery time to breathe, and then they'll give them a little bit more of the milk. The bigger babies, though, we find are more messy. They have less in the way of table manners. So they tend to squish the milk up and forward. So a bit like you're slurping, trying your dram of gin or what, a dram of scotch, and sort of squish it back in their throat and then squish it back in the cup again. So there's a lot of forward and backward flow of the milk. And then messy, at some point they will swallow some, but they do end up wearing some of it. So we would go for the cup choice if mummy wasn't there, if she was breastfeeding. But obviously if mummy is there, then we would encourage mum and baby to spend time trying to latch on and spend a little bit of time with mum about feeding hold technique and what's a good latch and what isn't, and just working with the baby, really working at the baby's pace. And as Sophie and Heather have said, some days are good days, some days are hideous. And it's just trying to play mind games with yourself to get you through the bad days. But know that each day is one day nearer to the day when your baby will do it and will sustain it and will go home. And that is really hard. I mean, especially for our mummies and daddies here, some of the babies have been born at 23, 24, 25 weeks gestation. So they're actually with us in a NICU for 6 to 8 months. I can even remember the days when babies had their first birthday in hospital.
I remember that. Actually,
so thankfully things have moved on from that. But it's hard to sustain it, and little victories are massive really in those mind games. So hold on to the positives.
Yeah, absolutely.
And talk about the negatives. You've got healthcare providers around you. You've got midwives. You've got health visitors. You've got neonatal nurses. You've got your friends and family. So talk to them in some way just to help you get through. And I think the friends and family thing nowadays, obviously we're isolating ourselves. We're distanced. You haven't got that physical contact. So it is important that you talk to people, that you don't feel shut off from the rest of the world, even if you are keeping within the 4 walls. So do talk to your family and let them know what you're going through. You know, tell your best friend, actually, this is really hard. I need some help here. I need some company.
And there is a lot, because of that, and obviously this has been going on a while now, a lot of the groups, so Breastfeeding Network, GBSN, I'm not going to go on too much because they've got a separate session, but they're both offering, Breastfeeding Network are offering virtual support groups, and GBSN are offering, what are they offering at the moment? There's virtual one-to-one sessions with a breastfeeding counsellor. All the breastfeeding counsellors in GBSN are all really, really experienced, really highly trained. I often kind of communicate with them. They're brilliant. Some of them supported me. I can't rave about GBSN highly enough. So there's those, they're free, 20-minute sessions. So if you want support that way, it's through the GBSN Gloucestershire Breastfeeding Supporters Network website. Breastfeeding Network, they're active on their Facebook. So they've got it pinned. I found out yesterday, they've got a pinned post on their Facebook page. So Breastfeeding Network Lactation Station. It's quite a memorable one to remember. If you, they've got a pinned post there, and there's 2 contacts, Anne-Marie and Zoe, with their telephone numbers. So they also provide telephone support. Then there's all the support mechanisms, the usual National Breastfeeding Helpline, Association of Breastfeeding Mothers, all the usual support mechanisms that hopefully you've already got details of. But I would imagine, so there's TAMBA out there for twins and multiples. I would imagine there'll be some level of virtual support for them. And I don't know if Tommy's or any of the preterm Bliss or anything.
Yes, Bliss does have some information. So if you go on the Bliss website. There's a lot of information on there for parents. I think there's info even for grandparents.
Yeah,
there's things about feeding, but also just how to care for your baby, how to enjoy the experience of becoming a parent, because actually it's a big step. You know, most of us don't have any training in it, and we don't know quite what we're doing until we have to do it. So it's good to have somebody else out there who's thought about some of the little pitfalls and give you a few tips.
And have they got, so you've got the Shed group here as well, haven't you? I presume they've got a Facebook page, haven't they?
Yes, so anybody who comes through our neonatal unit can join our Shed team and our Hope team.
Hope, that's
so
it.
Hope is helping other parents cope emotionally. And that's been set up by ex-parents from here, or our graduates, and they provide telephone contact. They've got a Facebook page, and when COVID's not annoying us, then they can come into the unit and provide some support as well. And also we have Shed as a spin-off from that, and that's support and help for every dad, because we do find that the male contingent of the relationship quite often thinks in a different way or feels a little bit left out,
particularly at the moment.
Absolutely. There's an awful lot of attention on mummy for obvious reasons, and then on the baby for obvious reasons, and then the other person in the relationship is quite often feels that they're on the periphery and that they can't offer anything, but they really are. They're the bricks and mortar. They're holding this all together, and they're the ones running around and doing everything. But they need some attention too. So Shed is a group of gentlemen who've been through our services, who have actually said, look, you know, we're happy to support men in the relationships. And
have you got the dad pad?
So we've got also the dad pad, which is an information booklet for dads as well, explaining some of the things that might be going on and constructively pointing them in the direction of what they could do to help, if need be, if they're at a loose end.
Because it's quite a steep learning curve, and isn't it, particularly with a preterm baby as well, and all the extra kind of worries and concerns and things going on, particularly at the moment as well. Is there anything else?
So we've got a project that's going on in the maternity services nationally, actually, called the Preterm project, which you might hear about in your travels. So it's looking at sort of making the baby's experience around delivery and in its early few months as good as it can be, and improving their developmental outcomes at the end. So part of that actually focuses on the way babies are going to be feeding, etc., and the support that can be given to mums around the time of delivery. So it's looking at the opportunities to express milk before the baby is born. So Sophie and her team help to get that message across, and will give mums some guidance if they're 36 weeks and upwards, so that they can actually start to get the ball rolling with the milk production, and we can store it here in our freezer for when the baby is born, or they can store it in their freezer at home. But we also have a lot of emphasis, as I've said already, on skin to skin, and we have a standard here that we're trying to make sure that the baby and the mummy, at the very least, can have some skin to skin or some physical contact within an hour of delivery, which is a challenge because sometimes the mums are very unwell, or they've had a cesarean section, or the baby's not well, so they've had to come round to us. But we move mountains to try and get mums and dads and babies together.
Dads do often get to follow the baby. So dads do often, for those any dads out there, they do often get to follow the baby around to the neonatal unit. And we have had dads go around with syringes, those little syringes that we've shown you of express breast milk. which staff are eternally grateful for as well. So that's always something that hopefully your midwife would be able to help you with. If you find you're in a situation where you're expecting to, you've been told by your doctor, right, we need to deliver you early. Ideally, hopefully, the staff on the maternity ward or wherever you are will support you with expressing. If hopefully there's opportunity. Obviously, it depends on how the delivery goes, I'm well aware, but if there's an antenatal period, even if it's a day or two, so you can get the hang of what to do and hopefully get some colostrum off. We also, so some of our babies get offered donor breast milk. Are you happy to chat a bit about that now?
So we have a stock of donor breast milk, which is supplied currently through Southmead Hospital, which is part of our neonatal network. And they have been given this milk by mums who have got lots to share. The mums are screened and the milk is screened. The milk is then pasteurised and it is stored in very rigid circumstances. It's monitored very, very closely. It's treated like it would be if it was a donated kidney. It's all well tested. And we can track the milk from the person who's donated it to the baby who's received it. So if you had a baby who would benefit from having breast milk and you're not able to provide it or provide enough, then donor breast milk might be an option. We would get consent from parents to use it in the first instance, and then we would use it in a way that we would with any other milk that's been given to the baby. So it can go down the tube, they can have it straight into their mouth, so we can use the cups, we could use a bottle if need be. And so they get to taste breast milk rather than having any other supplementary milks. And then as mum's milk supply increases or it's more readily available, then hopefully we can transition across from donor milk to having mum's own milk. So in some cases, we'll mix a little bit of mum's milk and a little bit of donor milk to try and eke it out a little bit so that the baby always has a bit of mummy's milk. I personally would always give mummy's milk first if they're having a suck feed, so they can taste mummy's milk first, and then I would give them the remainder of the milk, the donor milk. So any of you out there who have got a lot of breast milk, if you feel that your baby won't need it, then if you contact either the neonatal unit at Southmead Hospital
Milk Bank, I've done it before.
The milk bank, or if you can't remember, contact either Sophie or one of us on NICU, and we can give you the information. They will only take it if your baby has been discharged from NICU already, if yours was a NICU baby, and they will only take it up to 6 months of age of your baby, because obviously your milk will change after that.
If you Google Southmead Milk Bank, it takes you to it's Born Too Soon, I think, isn't it? But Southmead Milk Bank, Google that and it will take you to their website. They've got a website and it's got an email address for the team there, and contact them, and it goes from there. It is a very stringent, they take blood tests, and you have to fill in a really, really, really stringent kind of hygiene criteria, which makes sense, obviously. But definitely there's mums out there, certainly during lockdown, I've had more mums ask me, they've had an oversupply and they've asked me about expressing and donating. It's definitely on the increase, which is amazing. And have you talked about the benefits?
No, I haven't yet.
Yeah, actually. So there's amazing benefits to breast milk, particularly for preterm babies, whether it be donor breast milk or mummy milk.
Yes. So, even if you can manage to get, as I say, your 2 drips and a dribble in the first few days, even if you can't sustain it or don't want to feed long term, giving some breast milk has been proven to have lots and lots of benefits. There's something horrible within the neonatal world that actually upsets the baby's stomachs and can actually lead to very major problems. And that is called necrotizing enterocolitis, or NEC for short.
NEC.
And that can be, the risk of that can be reduced by 2/3, which is really important. If you have a baby who's sick and on any breathing support, it has been proven that they will have a reduction in breathing support days, and they will go home quicker if they have breast milk. And also it helps to fight all the infections and things that they might be exposed to just in the day-to-day world. But obviously, if they're having breathing support, particularly with a tube down their throat, they have increased risk of getting a pneumonia. So if they can have breast milk, it will reduce that risk by up to 60%, which is phenomenal. There are other things that happen to preterm babies or very small babies that's associated with their eye development as well. And there's a condition called retinopathy of prematurity, which has like an inflammatory response in the back of the eye. And again, if they have breast milk, it's seen to reduce that risk by 70%. And then there's the other things which 70%. You might have touched on, that it actually increases the baby's IQ as well. Actually. So the statistics I've got is 5.9 points. So that might be crucial. It might get you into the university you want to go to, or I don't know, pass your SATs test, whatever. So
cool. It's amazing stuff, isn't it, breast milk, and what our bodies do. Is there anything, I'm trying to think if there's anything else I feel like
the other thing that we use in conjunction with breast milk in NICU, even if the babies are going to have specialist formulas, we will actually give probiotics. So you might have heard of those. So with, again, the very small babies or the small preterm babies, we will squirt a little bit of this straight into their stomach as soon as they start to have milk feeds. And this helps to grow the healthy gut bacteria. You can probably think of yogurts that do that.
I was going to say, there's a lot in the media about that.
And that just helps to keep the gut healthy and reduces the risk of neck and the other inflammatory problems that they might have. And again, if they've got a healthy gut, then they're going to tolerate everything a lot better, and they're going to enjoy their feeds a lot better, and they're going to have fewer feeding problems.
A few infections and gut issues, and brilliant. Thank you, Mel. And the only other thing I think of is, so we were talking a bit about donor breast milk, and sometimes that's used while mum's increasing her supply, and often those mums that are trying to do everything to increase their supply that get great support from the staff here at neonatal, and sometimes kind of they might call Mel or myself or Emma, who's based upstairs on the ward, just to kind of, if there's any supply issues, so if any people out there are either worried they might do or kind of got risk factors, so there can sometimes be risk factors for milk supply issues, thyroid conditions, polycystic ovaries, if you're anemic or if you had a large blood loss after birth, diabetes sometimes, but there's lots you can do. It doesn't mean to say you can't, very much not. I've supported mums recently, something called insufficient glandular tissue. So it's quite unusual. That's that 2%. So you probably heard before, most ladies can produce enough milk, and then there's a 2% percentage of the breastfeeding mothers that actually can't produce enough milk. But actually, I supported some that actually with a lot of cluster pumping, support from neonatal staff, loads of skin to skin, and really proactive with the expressing, and actually they've managed to produce some breast milk, and it's been amazing. So it's never say never. There's all sorts you can do. I'm definitely in the world of breastfeeding, I'm quite eternal optimist. There's always something you can do. It's just seeking the right support. Anything else you want to add, Mel?
I don't think I can think of anything.
Have a think. Well, Heather, any more questions? Anything you more want to add? Any thoughts?
No, you were talking about undersupply. I think it's also good to look at oversupply. So I think when you're feeding and you're topping up, you're pumping 3 hourly. And when you suddenly start to switch to just exclusively breastfeeding. What your breasts have got and what your baby wants. And so I was huge, and I felt that I had a bit of an oversupply. And I think it's knowing once your baby starts spitting out those top ups, because you have that amount that you feel that you should be getting into them.
Because we become quite volume obsessed, don't we? When they're little and they're early, like you said it yourself earlier, we become quite volume obsessed, I think, because we're in hospital and it's hospitalized, I suppose. Okay, no, that's valid actually. I've definitely supported someone.
The breast, I trusted that she had it from me, and actually she didn't need that full top up. And I just reassured myself, and it works. I kind of stopped. I kind of dropped to pump slowly. So I would not pump, feed again, and then pump.
Yeah.
So my breast, and I found I don't know if anyone's heard of a hacker.
Hacker.
That breast that I wasn't feeding on and
Yeah.
took the milk, so I wasn't huge for the next feed, because she doesn't necessarily feed from both breasts at each time.
No, yeah.
Sometimes she just takes one breast. So it's, I know a friend that did struggle with it.
She's very content there, Heather. Content breastfed baby, like has just slept the whole time. I love her. The eyes are opening. Yeah, you're right. The hacker pumps can work really well, and oversupply is definitely something. Again, it's. I feel I see more milk supply issues and undersupply than oversupply. But yeah, it's definitely oversupply is a thing, and it can be managed with the right support. So it's definitely a case of, but it is. I would definitely say specialist support. So if there's a lady out there that feels that's an issue for them, definitely ask to be referred to either myself or Emma, the feeding health visitor, depending on the age of your baby. I had one last thought, but I can't. It's gone. Got baby brain. No, not baby brain. Busy mum brain.
Like you say, the take the good with the bad, because I was told by the consultant neonatologist that yes, she's continuing to lose weight, she's putting it on slowly, but there's nothing else you can do. You were doing everything right.
Yeah, he just said sit tight, didn't he? And he was just actually take a leaf out of his book, just sit tight, Russell.
Good.
Feel that you're obviously doing something wrong because they're losing weight, but actually no, just keep at it, and eventually it will turn the corner.
And there's a lot to be said. Often it's underrated, this following your trust maternal and paternal instinct. Heather, you said earlier about expressing and kind of dropping top ups, and actually what you followed what you felt was right.
Yeah.
And for those mums and dads out there, kind of whether they've still yet to have their baby or kind of had their baby, either or, there's a lot to be said of actually what's your gut telling you, what's your obviously not your gut that's hungry, you kind of just what's your paternal instinct, that little voice in your head that kind of, I remember it well, that whole, well, I was going to do this, but my GP told me to do this, or I was going to do this, but my best friend who had children 20 years ago that said only this. But actually, what's your maternal instinct saying? So I think just reminding parents of that. Similar kind of here. So what, and again, Mel, you said it earlier, what works for one mummy and baby might not necessarily work for another mummy and baby. So I've sometimes talked about expressing and feeding, particularly babies have short feed windows. So if they're only feeding for 5-10 minutes, actually you need to maximize that feed window. If you've got a lot of milk, maybe expressing off with a pump first for 5-10 minutes to get off the really more watery part of the milk feed, and actually then the 5-10 minute feed window, they're getting the really fatty part of the milk feed, the higher calorie milk, which is obviously what they need for growth and for weight gain. So there's lots of tips and tricks, and I think we do get a lot of feedback. Certainly I get a lot of feedback, I think generally we do in the unit, of mixed messages and conflicting advice is generally how it's given. But actually it is a case often of a midwife or a neonatal nurse might suggest one thing, but actually, okay, that's not working, right? With that particular pattern of expressing, that's not really working for that mum. Unfortunately, breastfeeding isn't very black and white. There's lots of grey areas. Babies don't necessarily do routines. They cluster feed. So we often talk about older babies do cluster feeding, and it's really common and it's really normal. And actually cluster pumping is a tactic we use really commonly in neonatal to increase a mum's milk supply. So it links to that. Actually, there is a physiological reason, not quite sure who designed it, because I remember mine did it over evening, so you used to have to eat with a tea towel laid over her head many a time. Yeah. I swear they can hear the cutlery or they can smell the food. They're convinced of it. But actually that's completely normal, and it's increasing your milk supply, and it does settle down as they get older. And would you agree, Heather, if I said as they get bigger it gets easier?
It gets easier. Yeah. Sorry, it's just, I was concentrating on it. It does get easier in the sense that you say it's just not as constant. It's not that 3 hourly. They find their own little routine and their own pattern. But then if they get older, it comes with their own challenges as well. Like
yes, yeah, absolutely. Yeah, there's new challenges
with that on and off and everything.
Yeah.
So it's just knowing that it's all normal, and you just have to sit and just sit for the day and feed, and that's what she wants to do. Oh,
Yeah.
I think she wants to feed now.
No, that's fine. Well, thank you for joining us.
Thank you.
I think if you're happy, we could probably finish up. So thank you very much, Heather, and thank you, Pippa, very much. She's been lush. She's been the idyllic breastfed baby. She's been the content breastfed baby.
I was just to say,
tell you about
the help that we got in Gloucester has been incredible, and I think everybody needs to know that they're an amazing staff, and I couldn't have done it without everybody. And that's from Delivery Suite to you, Sophie, because you were fantastic. To everybody on the maternity ward, they were just amazing. So
brilliant. Thank you, Heather. That's really good to hear, and thank you. And you take care.
Yeah, will do.
Oh, look at her. She's adorable.
Bye.
Bye.
Bye.